red blood cells, and then erythrocytes and leukocytes. Today we'll start on thrombocytes. So thrombocytes, platelets, are pinched off piece of cell. This is not at all a cell. Okay? They come from a cell called the megakaryocyte. What does, hopefully you know what mega might be, but does anyone know what karyote? Prokaryotes, eukaryotes, heard of those? Something like a cell. Something about you just said the single cell. It has to do, you said amoeba the next nucleus. Has to do with the nucleus, right? The true nucleus, the eukaryote like heart cells, like plant cells, prokaryotes don't have a true nucleus like bacteria do not, right? So megakaryocytes, it's got this large nucleated cell, it pinches off pieces, so pieces of nuclei also go into thrombocytes. These are the second numerous cells, right? Which are the most abundant cells in the blood?
Red blood cells?
Red blood cells, erythrocytes, right? So about 4 to 5 million per microliter. What about the leukocytes? Yeah, that's the Buffett burger that these two both belong to. Roughly how much? It's in the thousands, so 4 to 10,000. Here it's in the hundreds of thousands, so 150 to about 500,000 platelets, thrombocytes per microliter. What's the main function of this? This stuff, bleeding. So today we'll talk about how bleeding will talk in terms of 3 phases. This is going to take part in the second phase. So we'll talk about that too. So, what does penia mean? Penia, thrombocytopenia, it means less than. So, in patients who have less thrombocytes, that can be one of the side effects of steroids long term. So steroid is the thrombocytes count also decreases. Okay? So that could be because they do destruction. But here you could have too low, they can start to bleed more spontaneously or do not stop from bleeding if they do have an injury to the within the digestive tract, skin, even the central nervous system. So usually we're very mindful, especially if it's less than 80, it's quite dangerous. What does leukocytosis mean? Next question will be, what is leukemia? Which one? Which one? The first question. Yeah, leukocytosis talks about excess white blood cells count, but they are good functioning white blood cells, right? Leukocytes. So when we find an infection, we would hope and we want our leukocyte count to increase so that we fight that infection, right? While leukemia, white cell count does increase, but is it useful cells? No, they're non-functioning, they're cancerous cells, right? So thrombocytosis can also higher thrombocytes. What is low red blood cells called? Anemia. Yeah. And high red blood cell count? Polycythemia. Thrombocytosis is when we have too much, then it can cause, it's due to an infection, can trigger them to be produced. But we don't want too much because it can result in excess clot formation. So let's talk about this control of bleeding as part of clotting, if you will, but it's called hemostasis. Hemo talks about blood. It's stasis means kind of a balance here. We do not want to lose the blood. Okay? And we have 3 phases. So it happens when we have walls of blood vessels which have been ruptured and it cleans out, right? if we take off the top layer of skin, do we bleed? Epidermis, no, why not?
There's no blood vessels in that
There are
area.
no blood vessels, so hence bleeding, right? So you have to go to an area where there's blood vessels, and then start to see. The three phases are vascular phase, platelet phase, and then coagulation. Vascular phase, what do you think might be that referring to? It's the blood vessels themselves, right? When they experience a cut, their natural reflex is to constrict, right? So what will happen to that cut? It'll get smaller. When it's constricted, that opening will become small, right? So that will slow down the bleeding as well. Well, next phase is the platelet phase, when platelets kind of get together, aggregate, or platelet aggregation. Do we know of any medication that decreases platelet aggregation?
Aspirin.
Aspirin, yeah. We talked about it, it's called a thromboxane inhibitor because platelets release thromboxane, which is a kind of a beaming signal for other platelets to rise. Okay. And then the coagulation phase, that's the clotting factor. We'll talk about it has been three phases. We have an extrinsic pathway, intrinsic pathway, smooth pathway rather than phase. Extrinsic pathway, intrinsic pathway, and the common pathway. The common pathway is what finally leads to this mesh-like structure, which all cells, red blood cells, white blood cells, and platelets get stuck to. They form that nice little line. Okay. So vasospasm is what happens during vascular phase, right? So these blood vessels, when they're ruptured, when they become smaller, that opening becomes smaller. This is triggered by information that's coming from the blood vessel wall. This will lead to the next phase where these cells will start releasing chemicals which makes them more sticky, which means other cells that are passing through will be attracted to this area and combine with that area. So platelet phase here is we are going to have platelets aggregating, platelets collecting together. Here, it talks about fibers. These are not the fibers we're going to talk about in the next phase. So the fibrin, that's the network, that's within the blood vessel itself, it's going to form and clot. Here, it's just of the outer cells of the blood vessel wall itself, right? So platelets will aggregate, that's the thromboxane B2. The next one is the coagulation phase. So, what we need to take away? So takeaway is it's a cascade of events. So one enzyme, one chemical, when it becomes active, it's going to activate the next, and so on and so forth. Like domino effects, right? And we have three pathways. So I'll just draw it briefly, or very superficially. We have the extrinsic pathway. Just we get an image in our mind. Intrinsic pathway. Again, cascade, right? And then they'll meet, and then it becomes a common pathway. So this is the one I'd expect us to know the steps. It's really two big steps to make what really include where they come from, right? This, you need to realize where where the stimulus is coming from, and then same thing for this. How does it start? First of all, let's understand these terms and try to distinguish extrinsic versus intrinsic. What are we thinking about? Extrinsic, talking about outside, intrinsic, more inside. So here, it's actually talking about the blood itself. So any changes within the blood is the intrinsic pathway. In the blood vessel wall, it's still extrinsic pathway. Okay, and that's the trigger of those two pathways. Okay, so extrinsic is outside of the bloodstream, but intrinsic is activation of enzyme within the blood. Okay? So outside, if the endothelium, right, they've been broken, the bloodstream, they will trigger it inside with those pieces come off it, will trigger a reaction inside the blood itself. And then they'll join the factor that just join up is factor 10, it's also called Christmas factor. And then we have the common part. Here I would want us to know the parts. Okay? So it's prothrombin that gets converted to thrombin. It's an enzyme which has gotten from that common pathway. It's prothrombinase enzyme or thrombin converting. Okay, so it converts prothrombin to thrombin. So the thrombin is the active form. Prothrombin is just floating around in our blood. Then thrombin will activate fibrinogen, which is again an inactive clotting factor floating around in our blood. And that becomes fibrin. Fibrin is activated. It forms this mesh. Okay. A good visual cue, if you will, is the spider's web. Okay. It forms these thin stripes like with crisscrossing network. What's the idea of spider webs? To trap some of the insects that try to go through. Okay, here we're trying to trap all the blood cells across. Okay, that way it's going to stick, it's going to pull off all that. Okay. Factor 10 becomes prothrombinase enzyme. Prothrombinase enzyme will convert prothrombin to thrombin. Thrombin will convert fibrinogen to fibrin. Fibrin becomes this mesh-like network. All the blood cells get trapped, and hopefully by that doing that, seal all of them. Any questions? Okay. So here's an image to try and show that. So common pathways here. Let's just look at where the extrinsic versus intrinsic. Extrinsic, you're going to look at the wall of the blood vessel. Intrinsic is within it. So once, of course, it's stimulated by its factors that are released here. For example, platelets will also stimulate the intrinsic pathway. Right? That will convert. Again, factor 10 will come together to form prothrombinase enzyme. That converts prothrombin to thrombin. Thrombin converts fibrinogen to fibrin. Fibrin forms mesh-like structure where all the cells, all blood cells, not just platelets, white blood cells, red blood cells, get caught up in this mesh and will create a nice stuff. So, what are some other anticoagulants? Heparin, long-term, heparin, short-term, but a good one. Warfarin, right? So warfarin and coumadin, they actually block the formation of these multiples, actually 4 different, by preventing a vitamin, because we don't know what vitamin will. K is necessary in many of these blocking factors. You have K by an enzyme that binds it, we're taking off or production or reducing production of those factors. Who goes on coumadin? There are some patients that may be on coumadin. Post-stroke, they could be, depending on what kind. Right? Yeah, that's atrial fibrillation, that's the #1 reason for someone being on anticoagulants like coumadin. We don't do this much these days, but if someone has a metal valve, I think they last for a long time, right? What do we more often replace heart valves with? Animal, usually pig or a cow valve is what we replace it with. The pig usually is the better size fit. We replace it, they don't have to go on warfarin. But a lot of times they become 15-20 years down the line. So younger, again, it's about risk versus benefit. We're going away from metal valves because they need able to have high complex. But we used to give them, because a younger patient, we would put a metal valve we would put the immobilical valve in an older patient, because then, we don't have, the idea of the thought is we may not have to replace it multiple times. It's one more time, but here, we may have to replace it one time. 30-year-old, you would have probably 3-4 hospital changes, about 15 years. It's the normal lifespan. Which is why if you want to reverse coumadin, excess coumadin, we'll give them vitamin K as a last resort, right? Because it takes a long time for us to bring the INR back to the level. Then on this form as well. We will just give them 5 factors usually. So then after that, we will have this, once this clot has blocked the blood flow leak, we'll repair the back, and the clot starts to degrade. You might have seen wounds, right? Initially it's a bigger clot, then it retracts, and finally there's no clot, and underneath you'll see new tissue. So it's fibrinolysis we'll have later on. This will break down those fibrin as well after the clot starts to get size. Okay, that's after, it's not part of hemostasis, but you have to recognize that in the next stage, but it's not stopping. Now we've stopped it, we're building, repairing the cut from inside, and then now we can remove the clot. And you might have heard of clot busting drugs. That's what they do. And they are fibrin agents like Plasmon, TPA, you might have heard that. That's what they are, tissue plasmon, right, they will break down, they'll promote the fibrin breaking down. Who do we give that to? Two groups of, be specific about one.
Ischemic strokes.
Ischemic strokes, very good, you were very specific, right? Small strokes, what are the 2 kinds of strokes?
Hemorrhagic and ischemic.
And then hemorrhagic, right? Do we want to give this to hemorrhagic stroke patients? No, right? Because they had, generally it's an aneurysm that caused this aneurysm heart, right? Blood is leaking everywhere. You don't want to try more for them to do very hard, right? Ischemic, usually it's a blockage, which has resulted in hypoxia of this area, which is just outside. What's the other group? So kind of a similar thing, ischemia, a different organ. Yeah.
Could be used for somebody experiencing like an MI, a PE, DVT.
Yeah. MI usually PE we can as well, very good. DVT not usual, but yeah, those are things that can cause further damage, so reverse and we can. But again, under more like the emergency room can do it, or more under ICU similar setups. There's a chance that they would bleed from something that they were, if they had an aneurysm, for example, elsewhere, they would bleed from a certain. That's what they are. So we'll talk a little bit about problems with hemostasis, right? So one, it's talking about too much clotting, or the clotting's too more pronounced than necessary, right? So what does DVT stand for?
Deep vein thrombosis.
Deep vein thrombosis. What are some reasons we can have DVTs? Recent surgery.
Factor V deficiencies, lack of movement, lack of exercise, if they're bed confined.
Confined, exercise variable, yeah. Confined after surgery. Cancer patients. Long trips, yeah, because if blood just is stagnant, right? If you ever bled, you drop the blood on the surface, you'll see after within 4 minutes it should clot. Okay, that's what will happen in our blood vessels too. They're not moving, right? So surgery itself can make a high risk, as well as after surgery we're generally less mobile, and also cancer also is highly important to the state. Most cancers are, they also have high risk for developing DVT. What's an embolus? How is it different?
An embolus is a clot that is broken off from someone else's body.
And traveling, so it's a traveling clot, right? And usually it gets stuck in the lungs. Why? So usually it forms in the veins of legs, most common, again not exclusive, but it's the veins that form, right? Where does that drain into? Inside of our heart. Right side. So the blood vessels, when you come from, say, down there, the blood vessel diameter is increasing. Gets to the right side of the heart, it goes from atria to ventricle, we'll talk a little bit about it today. Then where does it go from our right side of our heart to? The lungs, the pulmonary artery, and then so on, right? So they're going to get, now it's going to get smaller and smaller and smaller. Okay? So the most common site is in the pulmonary. When we have a clot traveling, say, to our brain, it usually comes from the left side. Because there's a form in, actually usually is a defect in the heart itself, it forms in the heart, like AFib, for example, that can throw a clot. It's from the left, goes to all systems, including our brain. Brain is a lot more sensitive to decrease in blood supply, and then becomes stroke. So thromboembolics, this is too much undesired clot. Okay? And then bleeding disorders is usually due to either a decrease or a lack of one of those clotting factors. Okay? Then we have this scary one. It's called DIC. It stands for DIC. It means disseminated intravascular coagulopathy. This is in the same individual at the same time. They're having bleeding from certain parts, clots from certain parts. Why is this a challenge?
You don't know which medication you're doing?
Yeah, which one do we treat? Because we treat one, the other one worsens. Okay? So generally we try and find the cause of it, and then try and treat the cause and just keep them symptomatically managed. So some other causes are septicemia. If we transfuse incorrect blood grouping, we'll talk about that today. Pregnancies can also result, especially if they're having preeclampsia or a higher vessel. Both types of disorders, bleeding and extracoagulation, hypercoagulopathy in the same patient at the same time. So let's talk about blood grouping. First and foremost, I want to introduce something called antigen. Let's mention the immune definition of antigen. It's described as anything that can trigger an immune response. But now, for this chapter, just think of it, what makes our cells distinguish ourselves from other cells. Okay, that's what we'll think about now. Okay, antigens. So, what are the blood groups, the main blood groups that we come across? O, B, A, AB, and then negative or positive, right? So really, we're talking about three antigens that are that are different in all 8 blood groups. Then, okay. We do have other antigens, but these are the ones that are most important when transfusing until they become either they have had multiple transfusions. Then we start looking at other antigens too. Okay, but there are more, but these are the ones that we're going to talk about. So. A positive, right? So these individuals have 2 antigens on their cell surface. So, for example, we'll start with A positive. They have antigen A and something called Rh antigen. Sometimes it's also called the D antigen. Rh antigen was initially found in the monkey called rhesus monkey, so we kept that R coming from rhesus. Okay? So if they have it, it's positive. If we don't have it, that's when it's negative. Okay, so for example, A negative will just have antigen A. What will B positive have? B and Rh, RH. Present means it's a plus sign, not present or absent means negative. That's what the B negative. What about, let's do the A's first. Let me erase this up. AB first. What antigen will a person who has AB positive have? A, B, as well as RH, right? So, and then AB negative is A and A. There is no antigen called O. Think of O kind of like a zero, okay? It's when we do not have A or B, we classify as O. Okay? Hence, what antigens might a person with O positive have? Okay, no O antigen, right? It's just the RH antigen. Okay, there's no A, no B. That's what the O means. Okay? Well, O negative blood, they have none of these three. Okay? If O signifies they don't have A or B, negative signifies that they do not have RH antigen. But now we can think of surface mark. Okay, differentiate now each of our cells. So we do have a lot more surface antigens, but in terms of blood group, the main ones we look at is these three antigens, A, B, and RH antigen. So next we're going to talk about antibodies. So when we think about antibodies, you got to think about against antigen. Okay. So this will be what they do not have antigens to. Okay. So I'll help us with the first one, and always put anti in front. So individual A positive will have antibody anti-B. They do not have that antigen, so they will produce this antibody against. Okay? So what might A negative have?
Antibodies to the NIH.
Yeah. And I'm going to put the RH one in brackets. I'll explain why. Okay? Okay, they could have anti-RH because they do not have the antigen. What about B positive then? Anti. So if, for example, this person had anti-A, they will bind to their blood group, right? So we don't want the antibody which they would bind their own blood cells to. Okay? So it's anti-A. What about this one then? Anti-A and anti-RH. Again, I'm going to put that in parentheses and brackets. I'll explain why in a bit. What about an individual with AB positive? Should they have anti-A? Should they have anti-B? Should they have anti-RH? Because what would happen if they did? Would bind to their blood cells, right? So we don't have any of those three. So none of those three. What might an AB negative individual have? Anti-RH. Again, I'll put it in parentheses. I'll explain why in practice in a bit. What about O positive? Yeah. Should they have anti-RH? Anti-A and anti-B. These individuals
And the
and then the RH, right? A, by the way, where are antibodies found? I mentioned it on Wednesday. Where are they found? It's going to be in our blood plasma. Okay. So when we donate blood, what do we generally donate? The whole blood. But what do we generally transfuse when we say they got a blood transfusion? It's only the red blood cells. We do not get the whole blood. So we will not be transfusing blood plasma from a donor to the individual unless we need to for a certain different reason. We'll talk about that. Actually, I'll talk about it here. It's for clotting factors. Mainly we transfuse plasma. We take out the antibodies, but we give them the clotting factors. We also can use that for albumin, but nowadays we've gotten better at producing albumin in a different way. That's another thing that plasma to use, but we do not give antibodies. Okay? Serum is when we give the antibodies. Take out what we want. So, when an individual receives blood, they're only getting the blood cells, red blood cells. That's why it's also called packed red blood cell transfusion. Okay? So there we want to make sure that person's blood that they're receiving does not bind to our antibodies. Okay? Make a start on it. So let's talk about receive from and then donate to as well. First thing I would like us to see with this question is the same blood group. Okay? Same blood group can donate to the same blood group, they can receive from the same blood group. Start with that always. Okay? So A positive can receive from A positive. Could they receive from A negative? Again, you're receiving the blood cells, so the blood cells you're receiving, your antibodies should not bind to them. We can receive A negative because they only have, so this is what you're receiving, right? Cell with the antigen. So you can receive that, you only have antibody B, you will not bind. So you can safely receive from A negative. Can we receive from B positive or negative? No, because they have the B antigen. What's this one? Could we receive from AB positive? But AB positive has the A and the RH. But it also has the B, which is what that person's blood will bind to. So neither one of those two will work. What about O positive? Yeah. Because O positive only has the RH antigen. This one we're only worried about the antibody B being present, so only the antigen B coming in. So this person can receive from O positive. And what's the universal donor?
O neg.
O negative, that's another thing I hope I will see. O negative can give to everyone, so everyone can receive from O negative. Okay? Well, what about the A negative? First blood group you should have is
A negative.
A negative, right? You cannot go wrong. That's what you usually do. Can they receive from A positive? No, now they have antigen RH2, which will bind the RH. Okay? We can't get from B's, we can't get from AB's. What about O's? O negative only. Okay? So here we kind of a mirror of what we talked about, but instead of A's, we'll have B's. Okay, so B positive can receive from B positive, B negative, O positive, O neg, or B negative can only receive from B negative. What do we think about AB positive? What are we concerned with? Again, the antibody of this individual attaching to the antigen of the donated blood. Does this person have any antibodies? No, so they can receive from all 8 blood groups. They are called the universal recipient. They can receive from all 8 blood groups. Okay? What can AB negative receive from? You can receive from 4 blood groups. Which are they? AB negative, of course, good. A negative, B negative, and O negatives. All 4 negatives they can receive from. Their only concern is the RH antigen coming in. What about O positive? Can we give them A blood or B blood? No, because they're going to have both those antibodies. Can we give them AB blood? No, that will also cause blood, right? So it's only from O positive and O negative. What about our O neg person? Who can they receive from? O negative only. This is the same way, yes. One time and one time only they can receive from positive. But that's in a worst case scenario when you're in doomsday or out in the field or in a war zone, they may give us. How did they find this out? The history behind it was in World War I. People, they got one soldier, donated blood, straight away into another. Whoever survived, and whoever did not. They perished not only because of their wounds, but also this incompatibility. We didn't know that. Okay. Now we go. Now donate to, right? Now you're going to see the AB in order. Because they can donate to that. Right? So here, what should we first write? A positive can donate to A positive. So now you're worried about this person's blood attaching to the recipient's antibodies, right? So can we give these to an A negative?
Mm-mm.
No, because yes, this is fine, but this one will bind to it. Okay? So we can't give it to any of the B's. So we give it to a B positive. Yes, we can, because this person's blood has these antigens, while this person's blood does not have any antibodies. You're going to see this in all of them. Why? They're the universal recipients. So here, it's these two plus the negatives, right? I will write A negative first. B negative and maybe positive. Here it's B positive and AB positive. Here B negative, B positive, AB negative and positive. Who can these people donate to? Anyone with that blood group?
AB positive.
Anybody else? Just with AB positive. So if you have AB positive blood and you donate, they'll thank you. But they won't keep trouble. Okay. I'll get O neg blood on the dot, they'll keep running to come and donate. Okay. Same thing with O positive blood too, they'll donate. Last week we donate to 4 blood groups. Here AB negative and AB positive. Here we can only donate to all positives. A positive, B positive, AB positive, which will be O positive first. Here one more time in lab. So, what I want to talk about there, we also talk about something called agglutins, but before we end here, let's talk about cross reaction and what happens, right? So, if we have a match of an antibody and an antigen is when they bind together. And this is a good image which will help us to talk about it in lab. This clumping up. Okay, these Y-shaped structures are the antibodies. These red, the red blood cells with the antigens on it. If they match up, it's going to clump up, or it's going to clump up. Agglutinate is the right word. And then it's going to trigger the immune cells to do something about it. Okay? So they will agglutinate. What I do want to talk about is those Rh negative individuals and why I put in the brackets. Okay? So anybody who is Rh negative doesn't automatically produce the antibody against Rh. Okay? Whereas A and B, we have bacteria that normally live in our flora that have a similar antigen. So within about 6 weeks of birth, we'll start producing the antibodies. Okay? While to the Rh antigen, we do not produce it. We have to have first exposure, which is what I talked about in a doomsday situation or out in the field, in a war zone where you have no option. You can, only one time, you can transfuse a positive blood, so A positive to an A negative infusion. Okay? But one time and one time. Because once they do, their immune system's now been sensitized because they don't have that antigen. They start producing the antibodies against Rh. Okay? So we don't want to do that unless we really have to. Yeah.
Does it matter if you give them like 2 pints of blood at the same time?
Yeah,
Or
still it'll be
just
fine.
the once
The
and
first
that's it?
time's fine.
Okay.
Yeah, it takes a couple of weeks for it to really kick in. So you're fine the first time, first couple of days, you're fine. But after that, you can't. So the reason I'm bringing this up is mainly in pregnancy. Okay? So antibodies can cross, and for some reason, it's the anti-Rh that seems to cause problems. Okay? So if I have antibody Rh, whose blood will I clot against or bind to? Someone who has the antigen Rh, right? Everybody okay?
Mm-hmm.
So it's an Rh negative mom carrying an Rh positive baby that's okay. First time, no problems whatsoever, because really the mom's and the fetus's blood do not mix until we have 2 episodes. One is during delivery, then there's some mixing, as well as if there's some vaginal bleeding during pregnancy, there could be some mixing. Okay. So what we do to try and prevent the mom from being sensitized is we give the antibodies in advance. Fetal blood that gets into the mom's bloodstream that we want to prevent from eliciting the immune response. So we give the antibodies, so they'll pump up those few cells, the immune system doesn't know any worse. Okay? So that one is called the rail grant. Previously, we used to try and find out who the dad was or the sperm donor was, because again, this negative is a rhesus. Rhesus negative is recessive versus dominant. What's that mean in genetics? Does anyone know dominant allele versus recessive allele? Have you heard of it?
Not if you're
Not sure.
It's only if you're gonna get from either both parents or one parent recessive, only like both parents both have it, right?
Kind of, yeah. So if you, for the recessive trait to be visible, you must have gotten 2 of them. While dominant, if you get one of those dominant alleles, even if you get the recessive allele, it's the dominant allele that shows up. So Rh is a dominant. So a negative, Rh negative mom has 2 alleles which are recessive. Okay? So if there is a dad or a sperm donor is Rh positive, there's a 50% chance that the child will be Rh positive, right? He's definitely going to get one from the parent, but that one, the Rh positive parent, could be Rh dominant and then recessive one. So the recessive one comes through. So we used to play that genetic game previously. okay? That didn't work out so well for two reasons. Sometimes the person standing next to the mom was not the parent, and sometimes the mom didn't know. Okay? So we just don't ask the question, RH negative mom will get rheogrammed their ped bleeding during pregnancy, during delivery, we definitely will give them as well. So to prevent sensitization. So again, that first baby will not have a problem, but the second one or subsequent ones will if they get sensitized, because the antibodies will go into fetal blood, they'll clump it up, and we have to do actually in vitro transfusion. We take their blood out and give them fresh blood. And we keep doing that because the antibodies are going to go in again and again. Okay? And then after birth, we'll have to do it the first time, and then they'll be fine. But they will still have problems for the first few months. Okay, so we want to prevent that sensitization by giving this. It's usually in the mom's bedroom. Okay? And if they do not do it, we have what's called the hemolytic disease of the newborn. That's again for the subsequent pregnancy, not for the first exposure. Okay. Question?